Welcome, friends, family, community leaders, healthcare professionals, the people to Treating COVID-19, Know Your Options. I am your host, Dr. Joycelyn Wilson. This is number 5 of a series of 8 candid COVID conversations brought to you by Alive and in Color. Before I go any further, I'd like to personally thank Morehouse School of Medicine, the Black Cross, and the Gathering Spot for partnering with us and lending their platforms to this important cause. The purpose of tonight's conversation is to provide a trusted space for community to engage experts for a better understanding of the realities of COVID-19 and its impact on communities of color. Treating COVID-19 will walk you through the ins and outs of treating this deadly virus and will address topics such as levels of COVID-19 severity and when to seek medical treatment, treatment options, the opportunity in telehealth services, what you need to know about the CARES Act, options for the uninsured, RetroActive, Medicaid, etc. Once again, welcome. We appreciate and we value your time. Now, let's introduce you all to the amazing roundtable of panelists. I am going to have them chime in on what it is that they do to contribute to our community in under 1 minute. So let's begin by welcoming Dr. Patrice Harris.
Hello, and hello, everyone. I am Dr. Patrice Harris. I am a child and adolescent psychiatrist in the metro Atlanta area, but I'm currently the immediate past president of the American Medical Association. I just ended a 1-year term. I served as the 174th president and the first African American woman to hold that office. And it has been my privilege and honor to be able to lead that organization and the national conversations at the beginning of this COVID pandemic. One of the things we wanted to do at the AMA is to be a trusted, reliable source of accurate information. And I so appreciate this event tonight, so we continue to get out the information that is reliable, science-based, and trusted.
Thank you, Dr. Harris. Welcome. Let's go ahead and welcome Dr. Eric Flanaugh.
Hello, and thank you for letting me speak tonight. Yes, I am on the faculty for Morehouse School of Medicine. I'm the Chief of Pulmonary and Critical Care. I work in the intensive care unit at Grady Hospital and was part of the COVID response team that we put together during our first surge and throughout.
Great, thank you, Dr. Flanaugh. Let's go ahead and welcome Clifton Crawley, Mr. Clifton Crawley. Thank you. Mr. Crawley, I think that you're muted.
Yeah, I'm the chair of the National Advancement of Colored People, the NAACP community chair. I'm also a licensed medical social worker at both CHOA, Children's Healthcare of Atlanta, and Grady Memorial Hospital. I also serve as the therapeutic support specialist for DFACS, Department of Family and Children's Services. So that's what I do.
Thank you, Mr. Crawley. Welcome. And let's welcome our last panelist, Ms. Raquel Sands. Hello, Ms. Sands. How are you today?
I am great. Good evening, everyone, and thank you for this opportunity to be here, to be able to speak on this very, very important topic right now that everyone is facing. I've been a nurse for 20 years. I am also a disabled registered nurse. I went to New York at the start of when coronavirus became really, really known to everyone. When I left New York, up to 800 people were dying a day. I then went to Miami, Florida, where I worked alongside the National Guard, administering COVID testing and to a very, very impoverished neighborhood. I then went to Indiana. I did clinical research on one of the vaccines that is coming out right now. Even though that I am a disabled registered nurse, I still advocate for the elderly in my community and just anyone that needs any help. Nurses, we put our lives on the line, we put our families' lives on the line, and we continue to do what Florence Nightingale started in the Crimean War. Nurses will always be here from the start and until this pandemic is over. Thank you.
Thank you so much for being here, Ms. Sands. So let's jump into discussion. And I just want to set a couple of ground rules just so that we can have a robust conversation. And so just a couple of ground rules. Panelists, I want to ask that you keep all your responses concise and respect each other by allowing everyone to answer the question before chiming in. Whenever you want to chime in, just signal by maybe raising your hand or something, and I'll make a note. And just keep your mic on mute until it's your turn to talk, or if you want to hop in. And that's pretty much it. Let's just start with the facts, okay? So before we jump into the conversation, let's do a quick recap of some of the facts around the state of this virus and its impact that it's having on our community. So let's talk about Georgia and Fulton County specifically. They continue to have high COVID-19 infection rates. And it's interesting that we're even going to talk through this data because it changes. So some of this has probably even changed since we even got this data. So up to 40% of people who have had COVID-19 are estimated to be asymptomatic. We know what that means, right? It means that they could be walking around like everything's cool because they don't have symptoms, when in fact they are highly contagious. As of November 20th of this year, Fulton County is leading Georgia in county case rates at 35,149 cumulative cases of the 2019 novel coronavirus and 653 confirmed COVID-19 deaths. Of the 2,723 new cases between October 31st and November 13th, the central portion of the county, Atlanta, accounted for 43% of those cases. Positivity rates continue to creep up. As of November 20th, the positivity rate is 5.3% up from 5% a week ago. This is scary. We are indeed still in a state of red alert. So let's dive in and arm ourselves with this knowledge on the ins and outs of diagnosis and testing for COVID-19 and the flu. So how does that old adage go? The best cure is prevention. I want to just state that, you know, we've been wearing face coverings. Face coverings can reduce the risk of infection to the wearer by 65%. A fist bump transfers about 90% less bacteria than a handshake. Areas with no social distancing see 35 times the amount of coronavirus spread. Social distancing policies can reduce the daily increase of new coronavirus cases by as much as 9%. So I want to just put this out here to the panelists. This is to everyone. We're coming up on the holiday. Folks did travel, even though the CDC said that to not travel, but folks want to see their families. As we head off to enjoy the Thanksgiving holiday, what do we need to keep in mind about protecting ourselves from contracting COVID-19 and protecting our families? I'll go to you first, Dr. Flanell.
I think it's really important that people have a good understanding that this is a very transmittable disease, that you can actually transmit it before you actually have symptoms. So it's really hard to know when you have it and who you're spreading it to. And as much as we'd like to see our family, I've been telling my patients, I'd like to see them still alive or not hospitalized from something that's preventable. So it's really important. These guidelines and these recommendations are not intended to cripple us or keep us away from people, or you know, it's just a way that we can keep people safe and healthy for both the person who's yourself, along with the people that you wanted to see and spend time with, your loved ones.
Yes, yes. Dr. Harris, you want to chime in?
Yes, I have said that as people make decisions, actually throughout the pandemic, but particularly during the holidays, think of the people or the person you love and cherish the most. And think about what you would do to make sure that person is with you next year, next Thanksgiving, when we are likely able to be able to share those transitions. And so look at them and keeping that in mind. And then I think it's an easier choice to make the sacrifice. Yes, to do what we know. You mentioned prevention, wear a mask, not travel, stay home, no large groups. I mean, those are the things that we know work. Yes, we've seen some promise around vaccines. I know we'll talk about that later, and some medications that can treat. We'll talk about that later. But we absolutely know that wearing a mask, staying 6 feet apart, small crowds work. And I again agree that that old adage, an ounce of prevention is worth a pound of cure, should be at the top of everyone's mind these days.
Yes, yes. Ms. Sands, you want to chime in?
Yes, I surely do. The reality is that a lot of people are not going to listen. They are still going to have Thanksgiving dinner with their families. I've spoken even to the elderly and telling them, stay home and just have them meet you downstairs or wherever and just get your food and go. But for those that won't listen and still be a part of Thanksgiving dinner, you have to wear your mask. And when you wear your mask, you need to wear the mask properly. The mask does not mean that it's covering and your nose is exposed. If you're gonna wear the mask properly. For me, for Thanksgiving dinner, the close friends that are coming, I've told them, think of this as Golden Corral. At the front door, I'm gonna give you a mask, I'm gonna give you gloves, and you're gonna follow the line around, grab your food, grab your rum punch, and then I'm gonna be saying goodbye. So for those that are not going to heed the call of staying home, please wear your mask. Please remember that you love the people that you're around, and we want them to be alive and be around by Christmas.
Yes, definitely. Definitely want to be around by Christmas. Mr. Crawley, how do you want to add something?
I like what the nurse said. She was funny. The idea is that we want to stay safe. I myself, I think of it as sacrifice. You want to sacrifice for those that you love and you care about. And so for me, I'm not going to visit my mom or my loved ones this year. I'm going to take that time off. And I'll call them. I'll do a Facebook Live or I'll do a FaceTime on the phone, but I'm not going to go down there. I realize that I'm an essential worker. I'm a frontline essential worker. So I'm exposed. So I'm not going to go and put myself in front of my loved ones. But for those that are, I suggest they wear their mask, try to glove up if they can, try to stay 6 feet apart, limit the space to 10 people in a house or less, and just be very cautious as possible when, in a large group, and just think of it as a part of a sacrifice for your loved ones, and not think of it as so selfishly trying to get some cranberry sauce and turkey and dressing for one day. And just think of it as like, this one year I'm going to sacrifice for my family and for my loved ones. And that's how I told people around me.
So since we're on the topic of prevention, Dr. Flano, I'm going to come back to you. There has been a lot of talk in the news this week and last about the high likelihood that we will have a vaccine by the end of the year. Can you talk to us about the importance of vaccines in general and the role it can play in helping us beat COVID? And then I want to come to you, Dr. Harris, to talk a bit about how this is impacting the African American community.
Sure, gladly. So vaccines are, when they're developed and distributed appropriately, we've had a lot of success with conquering other diseases in the past. A prime example is polio. In 1955, the first vaccine came out. In 1963, they had an oral version of it as well. And as that was widely distributed, even worldwide, but specifically in the United States, we knew by the 1960s, there were only about 100 cases reported, and by the 1970s, only about 10 cases. So there is success when you have a program that develops them properly and can get it distributed to the people, especially those at risk. The flu vaccine is another example. We've known, even though it had to get an updated one each year, that it decreases the spread. And for those people that still might catch the flu, the severity of the disease is decreased. So we can slow the spread, we can keep people from getting sick. And if they happen to get sick, they're not as sick and dying in the hospital. And this has been effective for years. We hear a lot about this herd immunity strategy. And and for those that don't understand, the concept is if we increase the amount of immunity rate in the population, then enough people will be immune and maybe not get the disease or it won't spread to them. We have a problem with that in COVID. And the problem is that this disease is very infective. We don't yet have a cure. And when people get sick, they can get really sick, profoundly ill. For those people that have confirmed disease, the death rate's about 2.1%. So if we just allow the disease to spread, hoping that people will gain immunity that way, they'll get it and then they'll get better and then they have antibodies to it. The problem with that concept is that about 2.1% of people that actually get it are dying. And for a population of about 350 million people in the United States, that comes out to about 7 million people that would die just because of that. But it's not only that. We've seen about 40% of the patients that have gotten COVID require treatment, whether it's hospital or at home, which is about 90 million people. And even our ICUs, as you watch the news and you hear the reports, and what we've seen here locally is when the ICUs fill up, it overwhelms the system, the hospital system, and either other diseases are hard to get treated. And that's about a 0.2%. So that's about 23,000 people in the ICUs as of today. So the vaccine can be helpful. I'm encouraged that 3 companies are actually applying for FDA approval so it can be expedited and delivered, because that gives us more opportunity to immunize more people, because that'll decrease infections. It should decrease the spread and hopefully build up immunity. And for those people that happen to get sick, hopefully it'll decrease the severity of illness that they get.
So despite what we know about these vaccines, and you brought up polio, and I remember watching a documentary on polio that showed how the first time it came out, people got ill, that the first round of administering the vaccine made more folks ill. So I want to kind of double back on that part, because there's some skepticism, particularly in the African American community, about taking the vaccine. So despite what we know about the vaccines, 50% of African American adults do not trust the vaccine and don't intend to take the vaccine. Why are we so distrustful? Why is our community so distrustful? How do we know if we can trust this vaccine? And what questions should we be asking about the vaccine development process?
So a couple of things. First questions, or the first topic to post is, vaccines are being made. There's some part of the virus that you're training the body to recognize and then build immunity against, or defense against. But when that is exposed to the body, you are going to have some symptoms. People will say, I get the flu shot and then I get the flu. Well, it's really not you're getting the flu. You're getting the response as your body builds immunity to it. And I think we need to get people to realize that, yeah, you may feel bad for a couple of days, because that's your body doing what it's supposed to do to help fight that off. The flip side is, especially for African Americans, is that we are the population that is highest risk for dying from this disease. So you got to say, there's always a risk-benefit ratio we have to weigh. Is disease preventing it enough? Which we're hearing two of the vaccines have about 90% efficiency with preventing the disease. Is that going to be better than the risk of dying from it, which for our patient population is really high?
Can I chime in?
Sure, go ahead. And then Dr. Harris, I want to come to you. Go ahead, Mr. Crawley.
I think one of the things that people, Black people, and have a right to be skeptical when it comes to vaccines, is the history of medical practice in America. From the Tuskegee experiment to Henrietta, the experiments that were done to Black women for in the past, even with depot shots in Baltimore and up the East Coast, which made women unable to have children. So there's a lot of skepticism in the Black community when it comes to what the medical community has done to Black people historically. So that's why a lot of Black people have a lot of hesitation when it comes to vaccines or anything, when it comes to the medical community being presenting something to us. And a lot of Black people are scared to go to the doctor because of that. So that trust factor has to be earned and has to be reestablished for Black people in the medical community. And I'm not sure if we've done enough of that, or we've educated on our population enough when it comes to that as well. So that's where I think there's a disconnect.
So you bring up trust. Dr. Harris, I want to come to you. How do we know if we can trust this vaccine?
Well, and I do want to say, absolutely, we need to meet people where they are and respect that distrust. Yes, because of Tuskegee, because of Henrietta Lacks, because we know that Black women who were enslaved underwent surgery without any anesthesia. But as just was said, in order to get trust, you have to earn trust. And I believe, and I am a physician and a member of the medical community, that we have to go into our communities and we have to earn that trust. And the first thing we need to do is ask people, how do we earn your trust? Let us know. I can't decide for you. And so I want to ask, and I want to come to the community as a partner. We want to first of all make sure that people have correct information. And I think that is the other issue, which is why we have called on a very transparent process. Certainly, we have seen some promising results, but let's be clear, the results so far have just been released via press release. But we know that we have committees, external committees to the FDA. There has been a commitment that all of the data will be transparent. And so that's the first thing we have to see is the data is transparent. Physicians far and wide, other scientists, epidemiologists, virologists can then look at that data and then be able to work with the FDA and others to communicate that level of trust. And then that's when we need to go into communities and use trusted institutions, be that the church, religious institutions, hip hop influencers, whomever. That have had an opportunity to see the data and the science and work with them to get folks, Black and brown folks, to take the vaccine, because we are dying at higher numbers. I was glad to see there was an effort to get more Black and brown folks enrolled in these clinical trials, by the way. And it's not because race is a biological construct. I want to say that, race is a social construct, but it's still better to have diverse participants in a trial so we can know how different folks, gender, age, race, ethnicity, those with pre-existing and comorbid or co-occurring conditions will react to the vaccine. So it will be a slog, but I can tell you that all of the physicians I know are committed to making sure there's a transparent process, and we work with the communities to make sure they have accurate information.
So I have a follow-up question. What questions should we be asking about the vaccine development process? Like, what should, if in that building that trust from the medical community and the community, what questions should the community ask about the vaccine and the development of that vaccine?
So, just a few broad overarching questions to start with. First of all, how many people were in the trial, right? Mm-hmm. And by the way, as those of us in the medical community need to do whatever we can to stop using medical jargon. I'm guilty of that sometimes too, and make sure that everyone understands. But just how many people were in the trial? What happened? How many people got the vaccine? How many people didn't? For those who got the vaccine, what side effects were they? Mm. And we should be transparent about those that may be mild to a sore arm and a little bit of fever, because there will be some mild to any other more serious side effects. Of course, what you saw during this process, which I thought was a good indication that people really wanted to be transparent, is that when there was even a hint of a very bad reaction, they stopped the trial and won. So they were committed. And then they found out that no, that was unrelated to the vaccine. So again, those questions, what happened to those? How many people who took the vaccine became sick? How many people who didn't get it didn't become sick with COVID? So just those basic overarching questions. How many will I have to take? When will it be effective? Just those questions.
So I do have a follow-up. What is the difference? So one of the questions that, one of the conversations that I've heard and that I've been a part of is, there's Pfizer, they have their vaccine, and then Moderna has its vaccine. One has to be stored in sub-zero environment. Another one doesn't have. So what's the difference in these vaccines where one has to be pretty much frozen to stay healthy and another one doesn't require that? What's the difference there if they're both vaccines for COVID?
Well, and I don't want to get too wonky here, but there are different methods to make vaccines. And by the way, the two vaccines we've seen thus far have been developed using a brand new method, by the way, which is one of the reasons why we were able to get to an effective vaccine quicker. And I won't go into detail. But there are two new methods that were very advanced, but some of the other vaccines are using some of the tried and true methods, and that's okay too, because the more opportunities we have, the better.
Okay.
I know that the two Pfizer and Moderna trials, those vaccines are frozen. The AstraZeneca trial, that vaccine does not have to be frozen, and it can be taken at room temperature. So that's the difference in two of the three. The AstraZeneca one is now being up for approval as well. So we'll see. I don't know what the efficacy level of that trial in particular is. The Moderna and the Pfizer trials were, I think, 90%. I'm not sure what the AstraZeneca was.
And just wait, one more quick point. It doesn't matter the storage or how they're made. That doesn't necessarily, impact the effectiveness. So one could be able to be stored at room temperature and they both could be effective. I just, want to make sure that just gets to how they will be stored and transported. And of course, if you have to have a vaccine stored at a temperature the same as Antarctica, that would be a little bit more challenging, but that won't make it any less effective.
Okay. So, Mr. Crawley, since you brought up the vaccines, I want to ask you, can you talk a bit about why?
I believe the nurse had a question.
Oh, I'm sorry. Ms. Sands, you have a question?
I just wanted to piggyback on what everyone is saying about transparency. And with my patients, the questions that are being probed to me is, how can you be transparent with me when this is something that just happened? How can you guarantee me that I won't have any long-term effects later on down the line? The distrust in the Black community is greater than a lot of people lead on and say. And I'm here to speak on behalf of many of the patients, many of friends and family that call me or come to me asking me questions. So how can we go on being transparent when we don't even have all of the data? That's just what I wanted to say.
So I think a good connection to your point, Ms. Sands, is Mr. Crawley, who decided to participate in the Moderna trial. Can you talk a little bit about why you trusted the vaccine enough to participate in these clinical trials?
I did a little reading on it, and I knew that the trials, I knew that both the Pfizer and the Moderna trial, they didn't inject the actual coronavirus into their participants. It's a new way of which they were doing the vaccines. So they're not actually injecting the virus into people. So that's one of the reasons why I felt a little more comfortable being in the trial. But ultimately, the reason I decided to participate was because we were being disproportionately affected by the trial, by the COVID, and I was at CHOA at the time, and there was a 13-year-old boy who died. He was a Black male that died in the hospital. And I remember after going up and seeing him and thinking to myself, wow, how many other Black people are going to die from this, right? So I said, if I can do anything to help my people, I can at least, participate in the trial. And they needed Black bodies for the trial and to participate, because they were saying they had a shortage of minority participation. And I knew that in previous, I used to be a pharmaceutical rep, and I know that a lot of drugs and when they were going through the trials and when they were developing, they developed them for white men. And oftentimes the efficacy in minorities and in women is different because of that. So I didn't want that differentiation to occur with the new vaccine. So I wanted to make sure that I did my part to participate to mitigate that and to try to make sure that whatever vaccine is released to the public, that vaccine has a representation of Black bodies as well, so that it'll be just as effective in Black people as it will be in white. And so I said I'm going to participate, and I'm not. I don't have any children. I'm not married, and I'm not a coward. So I said, go ahead, let's get it. So I participated.
Did you have any? Did you feel anything, or was it?
It's a big needle. That needle is pretty big. I got 2 shots in my shoulder. The day after, it does sting. I don't know if I got the placebo or if I got the vaccine itself. They don't tell you that. But the next day, my shoulder was sore. They keep record. They give me an app to where I have to kind of keep a log of what goes on from that point forward. If I do get COVID, they'll send over people to assist me medically. So that's kind of unique. You know, most people sit in the house by themselves. I got actually some help that will come if I was to get COVID. And you know, that's kind of like one of the benefits of it. It goes through Emory, so I'm at the Emory Hope Clinic. So that's that way I work at CHOA, so it's kind of close to my job, so that helps out as well too. So it didn't hurt, but the next day it was a little bit sore.
Sure.
But I haven't had any side effects since then, actually.
Well, that's good to hear. Actually, you're the first person that I know who has even participated. I don't know about anybody else on the call.
I know one other person. I know one other person. But yeah, I did do that. We out there.
Ms. Sands, do you know anyone that may have that's participated in the clinical trials?
No, everyone is afraid, but the clinical trial that I was on back in August, only one person of color was participated, and you know, she was afraid, but to be honest, she did it because she needed money. So,
okay.
Yeah.
So let's shift our conversation and go into part 2. And that's, do I have COVID, and knowing the signs and what that could mean. So there's been a lot of talk about COVID-19 being like the flu. And while we know there are some similarities, knowing the differences is just as important, if not potentially life-saving. So Dr. Flannel, I'm going to come back to you, and I want you to tell us about some of the important ways COVID is different from the flu in terms of transmission or how it spreads.
Yeah. So this is, COVID has been, I guess, a real challenge in terms of how it spreads. It is spread so much more easily than the flu is, through just respiratory droplets, or even contact of aerosolized droplets that reach into the person, inhales them or whatever else. We find that it's really rapid in how it sets up. A lot of times when you have infections, respiratory infections, they kind of build up in the back of the throat or the back of the nose. It takes a few days, and then you start to exhibit symptoms. What we know about COVID is that it actually, you can spread it before you even develop symptoms from that. So it's what we call the silent spreader or the asymptomatic spreader. And then you can have it for about 2 to 3 days before you even start to show symptoms if you are going to exhibit. And then for about 10 days afterwards, after you've even recovered from it, you still have the possibility of spreading it. So it's something that you can catch it without knowing you have it. Before you find out you have it, you could have spread it to several other people. And then after you've sort of gotten better, you can still transmit it to other people. And what we found in the beginning is that one person that has it can spread it to about 3 people. Okay? And before they even know they have it, they spread on average to about 3 more people. So you go through a couple iterations of that, and you have 1, then it goes to 3 people have it, then 9 people have it, and then 27 people have it. And that can happen within a day or 2. And for those patients that are at risk, the elderly patients, those that have, immune compromised systems, either whether it's from medications or chemotherapy or HIV, And then some of the diseases that really affect African American populations, obesity, heart disease, renal disease. These are what's set up as setups for having sort of the worst outcomes and being a high risk for one getting it. And just, I guess, the way our community is so tightly wound, and we're very close knit in our families and our living environments, that it makes it easy to spread quickly through.
So I want to follow up on. No, I was coming to you, Dr. Harris, actually. Go ahead. I was going to ask a follow-up question for you, but go ahead.
Well, you ask your question and then I'll weave it in so I can make sure I answer your question. Yeah.
Yeah, thank you. So should we be concerned about the bottom of our shoes? When folks go out and maybe go to the grocery store, I know that I do. I know that my family, when we go to the grocery store or go out, we come back, we take off our clothes, we hop in the shower, we leave our shoes. Should we be concerned about it spreading in those ways? And are these good practices that we should be should have to keep ourselves healthy?
So I wanted to say one more thing. That was a great explanation of the symptoms. And we should be candid that it is not always easy to tell the difference between a flu and COVID. But there's one symptom that tends to be more common in COVID that you don't see in the flu is a loss of sense of smell. Yeah. And in fact, a lot of folks are saying that's how they first knew that something was wrong, is that they could no longer smell. And of course, taste is involved with how we smell food. So that is something that's not typical of the flu. But then there are the other symptoms, the fever, the cough, the shortness of breath. Some folks had some GI stuff, nausea, vomiting, and diarrhea. But what you just heard was some people never develop any symptoms. And they still could be positive. Now, of course, once you develop symptoms and you, get the test, then But there are some people who are positive for the virus and never develop symptoms, and they can be contagious. And the most common spread, and the other thing I want to add about trust is, at least in my experience with my patients, I tried to tell them what I knew, but I also was honest with them about what I didn't know. And I always found my patients to be to appreciate that and to trust me more when I was very honest and said, you know what, I don't know the answer to that question, rather than pretending to know something that I didn't know. And the other challenge for this virus is, remember, this is a new coronavirus. And so our knowledge about it has changed. And I know that's been very frustrating for the public, because they'll say, remember at the beginning, and I was one, we were saying probably shouldn't wear a mask, right? And one of the reasons why we didn't, know the transmissibility, and we didn't have a lot of masks. So I think I'm also very honest with, there are lots of things we know now that we didn't know at the beginning. One of the things that we know now is that this is most likely transmitted through the air, through droplets, less likely by touching surfaces, right? I remember when I, ordered in, I used to take wipes and rub everything. That's less likely, but it's not zero. So we should always just be careful, and we should continue to wash our hands, wipe down surfaces, and wear our mask and stay apart. I hadn't, and again, when people came in from the hospitals and things, they would come in and take off their shoes. Listen, there's nothing wrong with being extra careful. And so that's fine too.
Ms. Sands,
I'd like to chime in.
Sure, go ahead.
Yes. One of my patients, which it was kind of weird, she had hiccups. She had the hiccups, and the hiccups did not stop. And that's how she ended up going to her primary care. And they found out that she tested positive with COVID. People that I know that were positive, they had absolutely no symptoms whatsoever. My sister's entire household was positive for COVID. And the only way they found out was her husband exhibited signs and symptoms of the flu. I've heard some of the patients that they get really bad headaches or migraines. And I tell every patient or anyone that asks me any questions, know your body. If something is off with your body, get it checked out. And it doesn't have to just specifically be for COVID, but it's important for everybody to know your body, know how your body works. If something is off, if you know you're not a person that has a fever, go ahead and check it out. We're not saying that to go ahead and run to the doctor for every little thing, but it's very, very important at this stage for everybody to know their body and know when something is off, and to just be continuously be cautious and careful, because as time goes on, the data and the information that is given to us, it's going to continue to change. It's going to continue to build.
Ms. Sands, what did you experience in terms of COVID-19 and patient symptoms? What do we need to be looking out for?
When I was in New York, I had a 25-year-old patient, never been sick in his life, no underlying conditions. I left New York with him on a ventilator fighting for his life. And I've been told by some people, diet, oh, I'm on an alkaline diet. I don't have any mucus in my system. I can't get it. That's not true. You can have underlying conditions and you're more at risk for it. You cannot have any underlying conditions and still be at risk for it. It's important for everybody to know that we all are at risk, regardless of whether we have an underlying condition, whether we're obese, whether there are children. I remember when I was in New York, they were saying that kids could not get this. And what I didn't understand is children are human beings also, they're just smaller. And, it wasn't a surprise to me later on when, the first child to have COVID was in New York. And just be aware of your body, be mindful of others, protect others. We have nurses that are dropping down, that are mentally breaking down because we're out here fighting, and a lot of people are still not taking this seriously. A lot of people feel that this is still a hoax, and I appreciate everyone, both doctors, stating that they're honest with their patients, letting their patients know, hey, we don't know, because when the questions are probed to me, I'm honest with them and I let them know I don't know everything. It's important not to just stick to the news, but, go and do your own research. Go to the CDC website. There's so much information there. Talk to your doctors. Talk to any family member that is that's healthcare in the healthcare field, and get some advice. Don't just go off of hearsay. That's it.
Or Dr.
Yes. Say that again, Dr. Harris.
Or Dr. Google. There's so much. I'm so glad you mentioned CDC and other websites, because there's so much misinformation and disinformation out there on social media, like an alkaline diet or even vitamin D. Now, look, if you have a vitamin D deficiency, vitamin D is good, but there's no data about vitamin D. And if you are eating a healthier diet, that is good. That helps, your healthier overall. But again, this alkaline diet, I hadn't heard that one, by the way. But there's no diet to prevent or cure or treat COVID.
I think the idea is to put minerals and vitamins and things into your body that build and make a very strong immune system. And so I believe that's what folks are thinking, that, if I can just keep my immune system as strong as possible, and if I'm infected with COVID, then perhaps my immune system will be strong enough to fight it off.
Nothing wrong with that. We should all be, exercising and eating right. All the things that we know help our immune system. Taking a daily multivitamin, absolutely. But again, that's different to me from that will cure or prevent.
Sure.
Service of just being healthier. Yes.
Yeah. Definitely. But it's not going to make a difference at this point in time, right? It's always great, and in the long run, we need to start thinking about that as a community. More exercise, eating healthier, watching what we eat. I mean, that's what we need to think in the long term. In the short term, we are who we are, and this disease is what it is. It's very infective, and we have a very at-risk patient population. This disease doesn't care if who you voted for. It doesn't care how much you make. It doesn't care what street you live on. It doesn't care what kind of car you drive. It just cares whether or not you are at risk, you put yourself in a position to be infected, and whether or not you get infected.
Yes. I want to ask all of you all this question. Are there other uncommon symptoms you are seeing that we might not be hearing about, but that we should be aware of?
We've seen the general muscle aches and body aches. They talk about muscle pain, but it's very specific. A lot of the patients say it's almost as though I have worked out, and they can point to their thighs, their arms, because there's been some breakdown of muscles, some of your larger muscle groups. The smell along with the taste, that's very characteristic, and you've heard a lot about that. Some patients have said they've had headaches, it's very intense headaches, and they describe it as being kind of more frontal than anywhere, but I think that's just non-specific. And then we talk about GI issues, but very specifically, with the flu, you can get some nausea and vomiting, some diarrhea. In the beginning, a lot of the reports that came out of China was a lot of GI symptoms, more sort of lower GI diarrhea, and bowel incontinence. It was just kind of overwhelming. And incidentally, they would sort of get CAT scans or x-rays and notice that they were having some lung infections. So that the GI symptoms can precede some of the breathing symptoms that they get.
Dr. Harris and Ms. Sands, are you all seeing anything in particular when it comes to children or the elderly, something that's specific to children that we don't necessarily know or that we don't necessarily see, something specific to the elderly that we may not see in a young adult?
For me, with pediatrics, some of the patients, they had a rash. And that's all they had. They had a rash that developed, and then later on they had fever. For my elderly patients, they just complain of being very lethargic, very tired. They have no energy, but majority of them had either were asymptomatic or they had the, I guess you could say the most common signs and symptoms that's out there.
Okay.
But those are the only two things that stand out besides the one patient that I know that had hiccups.
Okay, Dr. Harris?
I remember at the very beginning with children, pediatricians were seeing what they were calling at the time COVID toes, right? So the extremities, the feet, and they were black and blue and purple. And that now we know is sort of inflammation of the blood vessels there. So that was seen quite early on in children, weren't quite sure, and actually initially weren't even sure it was associated with COVID, but now we know that to be the case. I do want to say on the other end, though, we've been talking about sort of COVID in the acute phase, right? If you have an infection. And I know it is particularly some young folks, the young invincibles, how I remember, would say, okay, most young people don't die, right? They have it. It's like a bad flu. And even I think some of us may remember even folks were sort of having even COVID parties and getting together. What we know now, though, there are some folks who are what people are calling long haulers, right? And so it's not that you just get, even if you get a bad flu, even if you are fortunate enough not to have to go to the hospital and be really sick, people are now having these symptoms for a long time. Months after. In fact, most people just saw, I believe, one of the hospitals in New York, NYU, I think they now have a clinic for this post-acute COVID syndrome. And so for some people, this is not going away. And so I think it's not just a matter of, oh, well, I'm young, I probably won't die, let me get it and get it over with. You could be, and again, it's not extremely common, but you could be one of the ones who, and some of these folks are saying they can't think, they have a brain fog. One woman who used to run marathons can't balance very well. She can't walk as well as she used to. And so really it's about prevention, and we really can't take this lightly.
So what happens, and I've heard this from a couple of folks who have dealt with COVID. They quarantine, they take their meds, they get better. It's almost like the hospitals kind of don't, some of them have the space, some don't. So you go home, you try to heal. Do you have to get tested again? You mentioned long haulers. What happens after the symptoms go away? Do you get tested again to see if you're positive? Like what's the follow-up from that?
Yeah, you do get tested again. You do.
Yeah.
Okay.
Now they've been the CDC's been trying to limit some of the over testing. We know after a lot of the initial symptoms have decreased or gone away, you may have a period of up to about 2 months to 3 months where some of the tests may detect elements of the virus being around, kind of a shedding, but it may not be active. So some of the latest recommendations have been saying, okay, you don't need the test within that period of about 90 days or so, unless you start having some more of the symptoms that sound like the infection is there. Outside of 90 days, if it seems like you're developing symptoms, then it would make sense to get tested again. You know, one of the things to be really careful about, and is we're learning about this disease as we go along, and we're finding out a lot of different things. Just even as it's spread from the beginning, some of the treatments that we're using back in the beginning here in the United States, we're no longer using. They've kind of shown not to be effective. And we're also learning that the United States has a very unique patient population, right? It's very diverse. We saw how the disease presented over in China and in South Korea and in Italy. We watched that transition and that spread, and they were able to pick out certain aspects and symptoms that developed the disease. In the United States, the population in New York City is different from Alabama, is different from Texas, is different from Arizona and California. And so we're learning a lot more as we go along. We can pick out some things, but we need to expect and get to our patients that we may not find out things later, this late long haulers disease, which is real. And even here in Atlanta, we're setting up clinics for this that are going to affect different patient populations differently. And they need to take it seriously in the beginning. And we go back to the topic we started out with, prevention.
Ms. Sands, I want to come to you. You served on the front line of this pandemic. You've been in New York, you've been in Miami, Indiana when it was at its peak. Can you tell us what that was like and why we should continue to be really concerned about overwhelming our healthcare system?
Oh, now I'm going to get on my soapbox and get emotional. What I saw in New York, we were not prepared. My actual dissertation project focuses on training. Every nurse should have disaster training. Nurses were breaking down, having mental breakdowns, crying because we felt so ineffective. It takes a very special person to be a nurse. Very, very special. We put our patients' lives before any and everything. And what I experienced, what I saw, what I heard in New York, it's something that I hope I never have to experience again, but I do plan on going back on the front lines again after I'm done with my DNP in a couple of weeks. One particular patient, he tried to commit suicide because he lost all of his family members to COVID. He survived. He jumped off of a 6-story building. He only broke both collarbones, and he tested negative. It was very strange in New York to not see the hustle and bustle. The only people on the road were nurses, army people, and the homeless. One of my nursing colleagues asked the homeless, well, what are you guys doing to protect yourself? And he just laughed and said, you know, you don't want to know. In Miami, I was in a very impoverished area, Opelika, Florida. Saw a lot of legal and illegal immigrants. The issue with that is, and the reason why it was such a super spread around there, the illegal immigrants were afraid. They thought that this was just a plot from the government trying to get them to come out of their homes to be tested and then grab them and send them, back home. But we were able to get the word out there that this has nothing to do with immigration or anything, and that you can come and get tested safely, effectively, and you will be protected. In Indiana, doing the clinical trial, it was in a nursing home. It was very sad. We didn't know whether we were giving the actual drug or the actual placebo. As I stated earlier, only one person of color out of the 9 people that end up qualifying for clinical research. Because with clinical research, once you get the approval, you have 1 week to do everything. Testing here in Atlanta, I've been on the set of The Walking Dead and other places. Everyone is afraid. Everyone is afraid, even those who don't want to believe. Think of the nurse in your family. Think of the doctor in your family. If you don't wear your mask, if you don't be cautious, think of what you're doing to that person. We are past the breaking point of hospitals being overbooked or have many patients. In New York, I saw the bodies being thrown into the ice cooler. The ice cooler wasn't good enough, and the whole neighborhood started to smell. I'm not going to get into the really gory stuff, but to sum it up, what I saw, I don't ever want to see again, but I know that I will see it again when I go back on the front line.
So to best reduce the severity of infection and avoid being a part of the critical scenarios that you just described, and what we've seen and heard, at what point should a person get tested for COVID-19?
That's a very good, very good question. Because like we said earlier, Dr. Harris said earlier, I think it's 43% of people that have COVID are asymptomatic. But the fact remains, again, you've got to know your body. Communication. I was around a group of people, and one particular person, after I checked them out, I told her 9 times out of 10, the symptoms that she had, she had COVID. And after her being tested positive for COVID, she had to inform, I would say, more than 25 people that she was sick. She had people in her family that she was exposed to. They didn't have any symptoms, but communicate with everyone that you're around. And if anyone is having any kind of symptoms of whatever, I would go and get tested. If you're not having any symptoms, but you've been around someone who said that they've been exposed, go and get tested. That's my best advice that I can give at this time.
Do you get tested if you just have a runny nose, Dr. Harris?
No, I would say no. And here, and I have to say, one of the failures in this pandemic, and there have been many, and some, and we'll go back and do an after action report, but one significant one was not having an overall comprehensive testing strategy that was clear and not invoking the Defense Production Act early on, so we have enough tests. So that folks even folks early on who were having symptoms couldn't always get the test. And I just saw even yesterday around the country, people are, by the way, with a false sense of security, getting a test to fly for Thanksgiving. Let's just remember that a test is just a snapshot in time, right? It's just a result of one moment in time. So it's not that you could get a negative test and then say, oh, I'm free and clear, because maybe you haven't even been infectious yet. So I would just say, I'm hoping to see a new testing strategy where the public is really clear about when to test, what type of tests to take. And I hope we get to the point where we are doing screening and surveillance, but we have to get there. And I have to sneak in, I'm a psychiatrist, and I wouldn't be worth my sought in psychiatrists not raising the issues around mental health. We don't have time to really dive deep, but I know, and we've seen that folks are experiencing more anxiety, more depressed mood, more sadness, and we will need to make sure that we have conversations around mental health and make sure there's support. And we saw a doctor in New York who took her own life, and we've, and I'm sure, folks are going to, have maybe some symptoms of post-traumatic stress disorder. So I want to encourage everyone to get help. It's not weakness or a failure if you ask for help. That is the ultimate in self-care.
Yeah, I want to piggyback off that. I've seen just in my own personal people around me, I've seen a lot of increased levels of anxiety amongst a lot of my peers. People are afraid to go out. People are very anxious. I know one personal friend of mine who had an anxiety attack just because they're just afraid. And then not just because of COVID, even it's a compounding thing. People are afraid of their financials. Some people have impacted financially. Some people have been impacted because they can't go out and they're not seeing a lot of people anymore. So that can cause some level of psychosis in itself. So it's been very this year's been very different, and it's been very trying. And I think that yes, everyone needs to check on their mental health and make sure that they see. Particularly now, there's telehealth, telemental health, and as a clinician, I'm sure that the doctor has some telemental health strategies that's going on. I know that I've been doing some telemental health on the side, so you can do that from your home now on your laptop. So I think that it's important that people go out and get the mental health checkups that they need, particularly now.
So, should someone be concerned if, so if you've tested positive, now what do you do? I'm feeling okay, but, a patient has tested positive. What do they do? What are the next steps?
I think when people test positive, it's good to try to figure out whether or not you are, or pay attention to whether or not you have symptoms or not. The whole process or the whole development of the disease, it has sort of 5 different categories of presentation. But there's an asymptomatic or pre-symptomatic period where you may actually test positive, but you don't have symptoms. There might be the period right before you start to have symptoms, but you still can spread the disease. So that would be a period where you'd say, okay, I need to get into some of those measures where I self-isolate. I quarantine myself. I let people who are close to me and around me know so that they are taking appropriate precautions, that they're making sure they're washing their hands, they're distancing themselves from me, they're wearing a mask. And then I'm also getting a little bit more detail in how we're keeping things clean around my environment. But then they pay attention to any of the symptoms that might develop. They might have some mild symptoms, where it's just kind of muscle aches and flu symptoms and whatever else. That usually comes in the first 3 to 4 days or so. Low-grade fevers, as long as you don't have any difficulty breathing, or if you get seen, you don't have any change on the x-ray, that's just kind of mild disease, and hopefully it'll resolve. And I think the vast majority of people are going through that process. It's just when you start getting more moderate symptoms, okay, the fevers are really high, to get 101 or so above. You start noticing that breathing's a little bit more difficult. You're not doing as much as you could. You find yourself very limited in your daily activities. That's the time to reach out to your healthcare provider, your physician, and say, hey, look, these are the symptoms I'm having. I walk from here to my bathroom and I just can't do it. Or I'm completely exhausted. I hit fevers that are several, really high several times a day. What should I do? And then you would take direction from them. If they think you need to get checked, go get seen, then they would advise the direction to go. Now, when things start to get severe is when you are seen, or you start really having really difficulty breathing, even just at rest. You're breathing 30 times a minute, or if somebody actually measures your oxygen when you go see a physician or a healthcare provider that's actually low, you're needing supplemental oxygen. And that's probably about the time you find yourself being hospitalized. And then we know the most critical state, and that's when the patients have difficulty breathing, they get intubated, they're on ventilators, they have kidney failure, or require other organ systems that are not functioning well.
I want to ask a question about the testing. So the way in which the tests are administered, the swabbing of the nose, there are folks, essential workers, who are having to get tested daily or every other day. Should we be concerned about the swabbing of the nose, how far the swab goes up in the nose? Should we be concerned about any of those types of things?
I think we need to be concerned that they're doing it correctly and that they're getting a good sample. I mentioned or alluded to a little bit earlier that most diseases that involve your respiratory system, the places of entry are either through the nose or the back of the throat. And those are the two areas that they have to collect the symptoms from. Just not right in the front of the nose, but you kind of have to get past back, and it's just a pathway to just go straight back. That's where they need to get the swab in there, maybe let it sit or turn it a little bit, or even go to both nostrils to make sure they're getting enough sample to collect enough virus so it can be detected on the test. The flip side is if your nose is sensitive, you can't do that. They can swab the back of your throat. Keep in mind it's an area that you may, yes, potential to cause you to gag. Uncomfortable, it's brief, but the information that can come back from being tested when you have symptoms or there's concern that you might be infected could be life-saving.
Yes, Ms. Sands.
One of the things that we do when we're about to test someone nasally, we have them blow their nose. And by blowing their nose, it will bring up any secretions and whatever that's in the sinus cavity. In terms of stating how far you should push the swab up the nose differs because everybody's nose is different. Some people have shorter nasal canals. So a lot of people have a lot of septum deviation. So whomever is administering the test, I always tell any patient, you should not be in pain. You should not have any nosebleeds. And the person, whoever is administering the swabbing, they should assess the inside of the nose to see how far up they would need to push the swab up. And we were told in the beginning up to 12 to 15 seconds, and then it was decreased to 8 to 10 seconds in each nasal passage.
If I could say, there are, and we won't go into all the types of tests tonight, but there are different types of tests. There's the test that's, pretty far up your nose. But I will say that I had that test and I was really worried because people had said it's horrible. And it wasn't that bad. Now, let me just say, I'm not judging because I am one of the ones that am terrified to go to the dentist for teeth cleaning. So we all have our own issues. But sometimes I think if we tell people, oh my God, it's horrible, it makes people afraid, to go. So it might be a moment or two of discomfort, but that diagnostic test is further up the nose. But there are other types of tests. The antibody test, people are using saliva. People are using finger pricks. So each of these tests are different. They each have their own, of how accurate they are. And so people can go to the CDC, I think, website. They talk about all the types of tests that there are. It is pretty confusing right now. And I think we could do a better job of explaining all the different types of tests and what they do test for and what they mean.
Yes, definitely.
I've been tested 8 times. So after about 1 or 2, it kind of gets easier. So I've been tested maybe once a month. So it's all good.
Is this
So,
or are you choosing to get tested once a month?
Well, when I was in the trial, initially I was tested each time I went to go. Well, I'm still in the trial. Each time I went to the clinic, I got tested. Before I participate in the trial, I got tested just to make sure I was okay because I am a frontline worker. So I didn't want to expose others to anything, just being out. So because I am exposed more open, I have more opportunity for exposure. I just wanted to make sure that I was straight. So each month I would get tested. So I've been tested once a month at minimum. So I've been tested 8 times. So it's just to keep myself aware. I haven't been positive so far. So
Frontline workers, when I was out there, we were tested every week. Every week we were being tested.
I want to put out a caution, if I may. There's a lot of companies you can see, especially if you're watching late night television. They're talking about, oh, we have the test. You can test at home, and you can purchase this and whatever else. You can test anytime you want, whatever else. I just want to have a little caution about that, and I'm not sure we're at that point yet. I think sometimes misinterpretation of the test and why you're testing and having it too convenient could, as was mentioned earlier, could lead to either overreading or underreading what your symptoms may be or your lack of symptoms may be. For example, people getting tested to clear yourselves coming home for Thanksgiving. Well, it was said earlier, that's one point in time. But it doesn't necessarily mean that 10 seconds after you do your test, you're infected again. And with that, the flip side is, even though you're negative and you ran into somebody, it doesn't mean now all of a sudden I'm infected, I need to go back home and test again.
This is all good information. I want to, before we start taking some questions, I do feel like it's important for us to talk through this next section, and that's on barriers to getting our most vulnerable connected to care. And so this is really personal to me. We've just told people when to seek medical attention, but from what I understand, some of the disparities we see in COVID hospitalization and death rates in communities of color has to do with the level of uninsured and underinsured patients in those communities and their lack of access to care. I would add, even if you are insured, one of the most vulnerable are our elderly. So I would add them to that. Dr. Harris, can you help us understand the connection between the lack of affordable health care for all and the high rates of COVID hospitalization and death rates in communities of color?
Yeah, people without health insurance live sicker and die younger, no question. And if you don't have, again, a routine provider, routine source of care, you tend to put off preventive care if you can't afford it, or you might have to pay out of pocket, or you postpone care. And we know that sometimes by postponing care, disease states are identified later. And early on, and even I remember originally we were saying, if you don't know whether or not you need to get tested or if you are ill or not, contact your provider. Not everyone had a provider. And I remember saying, we have to change that and we make sure now it's local. And so in Georgia, I might need to say, call, your Fulton County Health Department, the DeKalb County Health Department, or call your local federally qualified health center. So I think we, and I work real hard at making sure that we put out all the options, appreciating that not everyone had insurance and not everyone had a routine source of care. And that, of course, is why we really need Medicaid expansion and all the other, ways we need to work on as a country, as a society, to make sure everyone has access to affordable, meaningful health coverage. And then again, we've seen the numbers. They don't lie. We saw this early on. Unfortunately, in some of the cities that were impacted, they were able to demonstrate that Black people were in the hospital more and they were dying more. And I remember talking to our Dr. Aletha Maybank, who's the AMA Chief Health Equity Officer. Typically we don't get that data until afterwards, right? After we get through, people said, oh, you know what? Black and brown people died more. Oh my, what? And so that was sort of partial good news. Unfortunately, not every state, city, town, or CDC was collecting that data in a standardized manner. That's getting better, but we still aren't where we need to be. But just overall, African Americans, 13% of the population, 25% of the deaths. Latinx community, I believe maybe 18%. This is nationwide. And again, these numbers change, 25% of the deaths. And so clearly, Black and Brown communities have been impacted. Now, I want to say again, because there was some conversation, I think, early on, and people began to blame Black and Brown communities. And really, it's not race, it's racism, it's structural racism, right? It's those social determinants of health, lack of access to health care, transportation, jobs, housing. So we really want to make sure that certainly choices, we talked about diet earlier and being healthy, are a part of this, but I always say the choices you make are based on the choices that you have. So clearly Black and Brown communities disproportionately impacted, and really we need to be on a journey, and we will continue to have this conversation in our country of making sure that everyone has access to affordable coverage.
And then folks have lost their jobs as well. So,
absolutely.
You know, Mr. Crawley, can you tell our audience some of the options they have for getting treated if they lack health insurance?
Well, you can contact Fulton County Public Health, and they have some options available for treatment. I know at Grady, we offer them to go to Fulton County Public Health. I know that the state of Georgia actually has some housing assistance available for you. There's a housing facility actually near Forsyth, Georgia, for patients with COVID. It's actually, we call it the COVID hotel. They're sending people to down in Forsyth, Georgia. There was once, and I think they're probably doing it again at the Georgia World Congress Center space that was dedicated for COVID patients, that they were housing people who had COVID. That was more for nursing home and patients who were being hospitalized because of the overflow. They were housing them inside the Georgia World Congress Center, so they instead of inside of the nursing homes at one point. But unfortunately, it's not a ton of stuff. We have the Augusta University. You can contact DFACS, but in a way, this current administration has dropped the ball for people who are uninsured. It's unfortunate. There's not a lot of options out there, and it's telling what our priorities are as a country when it comes to people. If you don't have the resources, you don't have money. We just, I can't. When you look someone in the face and say, "I'm sorry," there's nothing really I can do for you. And that's pretty much honestly what I'm having to do for a lot of patients when they don't have insurance. There's really little I can do for you. And I give them some information as far as the Georgia crisis access lines and the Fulton County Health Board, and that's all I really can do, unfortunately. And yeah, that's it.
Yeah. I want to go to some questions in the chat. There's a question from Janine. How does COVID affect individuals with sickle cell disease?
I can mention that we've had a couple of patients that came through with sickle cell disease. So already, sickle cell disease is multi-system. Sickle cell affects multiple organ systems in patients that have it. It's a chronic disease state. And it's the sickling of the cells where the cells change their shape. They're especially in challenge situations when oxygen levels drop or other infections set in. If you think on remember how COVID actually affects most of the people that had respiratory failure, difficulty breathing, right? And so if you have that and your oxygen levels drop, the sickling gets worse. And so now you have two processes. You have an active infection with a virus that spreads through multiple organ systems with an underlying condition that affects many organ systems. So it becomes a challenge. These are very challenging patients to treat because you had to fight the disease causing the problems, and then the response that to the disease that was causing the underlying comorbidity to have a problem. And it just puts them at a very high risk for having a bad outcome.
I have a follow-up to that. So you mentioned respiratory. A lot of folks decided to buy thermometers or oxygen saturation devices or any of those types of things to have at home to try to, I guess, take care of themselves if they have to go to the hospital, or have just some information before they end up having to go to the hospital or determining whether or not they're sick. Would it be wise for someone who has underlying respiratory issues to have a nebulizer or something in the home to kind of fill in the gap for if, waiting on 911 to come to the house? Because my understanding is having those underlying respiratory issues, the time is ticking if your body gets attacked by this virus. So are there some things that we should have at the house to kind of fill in the gaps on the way to the hospital or anything like that?
Most of the patients that have these underlying conditions already have their own equipment. They have their nebulizers. If they have oxygen at home, they have their home oxygen and other medical devices. I think what's important to do is during this time period, take advantage of any telehealth medical visits, any communications you have with your healthcare providers, and have these discussions of, hey, look, I'm an at-risk patient. When should I be concerned? When should I not be concerned? And when do I contact you? And then that will tell you, okay, they'll give you instructions on, well, when's a good time to use the thermometers. If you do have a pulse oximeter oxygen saturation device to measure oxygen levels, what levels to pay attention to, and what are the trigger points where you need to notify or come into the hospital to be seen. What we've seen from patients that do have some devices and a few things and other medications is they wait too long. This disease it can kind of smolder along, then all of a sudden it just flares. And people just kind of take the symptoms there, they self-treat themselves, and they wait a little bit too long to where we're really trying to play catch up by the time they come to the hospital. We saw that here. You've seen it in some of the other hotspots around the country, and I think New York had it really hard.
Another question in the chat is for you, Mr. Crawley. What adjustments, if any, did they make for African Americans in the trial, and what can we do to have more of us sign up for these trials? We kind of talked a bit about trust, but did you notice any adjustments that were being made for African Americans?
No, not in the trial. They didn't make any necessarily adjustments. What I did notice is there was a big push for African Americans through social media, through the radio. They contacted some HBCUs. I read about getting more African Americans to participate in some of the trials, some other institutions. As far as the trial itself, I didn't recognize anything specifically different aimed towards African Americans. But as far as building trust, I think that's again is something that the medical community could do to show that Black people, medicine works. Medication works. This helps you get better. This treatment, vaccines work, and not just with data, but with proof that vaccines do help you, and vaccines do prevent these other ailments from occurring within the community. And I think that they have to get out into the communities and show and be a face and be aware and be a part of the community to help teach that to other Black people in the communities, to be a presence in these communities and to build that trust back within these communities, because right now I think there's a level of disconnect.
Yeah.
And there is a push to have more African American researchers, right? Because we know that the data shows, a couple of studies, that Black men are more likely to follow the recommendations of a Black physician. And so I believe that if we have more Black and brown scientists, doctors, epidemiologists doing the research, that also can go a long way. I also wanted to say something about telehealth too, because here was another disparity. And we talked about, well, just, use telehealth. Not everyone had a data plan, right? Not everyone had a smartphone. Not everyone had broadband access. So, I started to say, oh, we have to know. One of the things that the federal government did was they relaxed the rules, and physicians could do, other therapists could do just telephone consultations, and that was allowed. And so that was good. So you didn't necessarily even have to have, a smartphone and a data plan and broadband access. So again, I think there have been some efforts made to make sure that we were addressing some issues. Of course, we are, behind the 8 ball in health inequity, so we have a long way to go.
I think there needs to be a push just in general for just more Black physicians. It's a tremendous disparity. We're underrepresented in the medical community, and we just need more Black physicians, period. I think there's been a study that more Black physicians serving in the Black community reduces the makes it a healthier outcome for Black patients, and if they're seen by Black physicians. And unfortunately, a lot of our people aren't seen by us, and because of that, we are seeing disparities in our community when it comes to our health. And we need more Black people as doctors, as nurses, as social workers, as everything in the medical community, period. And I think that will reduce the mistrust and build trust within the medical community back within in our Black community as a whole.
Yeah, Ms. Sands?
I just wanted to chime in on what Mr. Crawley was saying also. In my years of being a nurse, that was one of the biggest things that the Black community never saw help, because they didn't have a Black doctor. And one of the things that I remember clearly is they said, well, he didn't look like me. How is he going to tell me what to do with my body or whatever, when he's not me? He's not one of us. So I don't know right offhand what can be done, but more education is needed out there, just as well as we need more Black doctors and nurses and people of color, so that when we're treating our patients, they feel more comfortable by looking up and saying, hey, this health professional is one of us.
Not only that, then we also have more empathy for the community that we serve. I've had to step in and oftentimes and serve as a mediator between the staff and the patients, because the doctors oftentimes either are perceived as arrogant or come off disrespectful towards the community in which they're serving, particularly at CHOA. When they're dealing with some of the children within our community. So I really, really strongly hope that we can get more Black doctors, more Black nurses, more Black people in the medical field and the medical profession. I think that will serve us well in treating within our community and building that trust back.
I want to stay on that for a moment, because we're talking about kind of like, where do we go from here? Like, what are some next things? And so I want to thank everybody for just hanging in here, because, we have a lot of important information that we need to get out. And I'd like to end this conversation on actual methods of treatment. Like, we've talked about so much. We are ending this conversation of saying more Black professionals, more Black nurses, more Black doctors. We need to let people know that getting COVID-19, even a severe case, is not necessarily a death sentence, but it is very serious and it requires care. And as you said, Mr. Crawley, it requires empathy and it requires compassion. Dr. Flanaugh, I want to come to you, and I want to know if you can tell us some of the ways in which the medical community is treating more severe cases of COVID-19. What have we learned we're learning by doing, and what's working?
So we're learning that, as I mentioned earlier, first is that educating the patients and educating the community, right? So they're not staying at home too long by the time it's spread, and we're not trying to play catch up with this disease. And then we've seen, and it's even for the medical community, it has been a learning process throughout, because medications and therapies that were touted and used early in the beginning, they're later found to be ineffective. We found don't work, and things that we're kind of discouraged from using were now very effective. Common things like steroids. Steroids are shown to be very beneficial in decreasing inflammation for those patients that have severe disease and trouble breathing. It gets some of the respiratory symptoms down. We found out that there's a lot of problems with blood clots. And so as patients come in and if they have problems with blood clots, or if they have certain markers in their blood work which show they're at risk for developing blood clots, we're thinning their blood ahead of time. And we're also paying attention to those patients that may have had prior history of blood clots or heart disease or strokes that would be at high risk. There's been one of the medications approved was the remdesivir. You hear that mentioned quite a bit. That's been shown for those patients that are actually hospitalized with severe disease, that they can, it helps get them out of the hospital, so almost 4 to 5 days earlier than what the average stay for those patients that haven't been on it. There's some more therapies in the works. They're very experimental. The convalescent antibody treatments and plasma infusions. That's not widely available everywhere. Some of them are still in studies. And so we're learning more as we go along on how to combat that. But those are some of the things that are out there. I do think, and I'm going to circle back around a little bit, that part of medical treatment that was mentioned earlier is outreach, communication, and education. And for those patients that were hospitalized, they couldn't see their other family members. We made efforts not only to make sure that communication was occurring with the patients and their families, and promoting that, but also educating those family members around them. Because we've seen the situations where you have entire families that are affected by the disease. And any efforts we can have to get outreach to the populations that we serve that are at risk. For example, this format, I find is very useful and helpful, and that's part of the treatment, that prevention that we need to be focusing on.
So we have come to the end of our conversation, but before we log off, I want to do a couple of things. I want to mention next week's conversation on the 3rd of December. It's going to be focused on minding the mentals, the mental, behavioral, and developmental care for everyone in the family. And I want to tell our audience that they can go to aliveandincolor.com for the latest information on the COVID conversations. As we wrap up, I would like to just ask if you could give the audience just a minute or two, a takeaway, a lesson, a nugget of information to leave with everyone as we begin to log off and go into our holiday and our holiday season. We want to be around our families. What is something that you would like to leave our audience with as we begin to wrap up tonight? I'll start with you, Mr. Crawley.
Mask up, stay safe, but also enjoy life. Find those times to make sure that you can still enjoy life. Walk, go outside, look at, go to the park, go to a creek, whatever it is, to get your mind clear and to still enjoy your time to yourself and enjoy life. Because don't let everything get to you, and don't let it all stress you out and give you anxiety.
Yes, Ms. Sands.
What I would say to everyone going into the Thanksgiving holiday and the other holidays that are coming up, just as Mr. Crawley said, please wear your mask. When you wear your mask, the mask does not mean that you put it under your nose. It must cover your nose. please, 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 because the nurses, we're tired, but we're still giving our all. And we're going to continue to give our all to make sure that each and every patient is taken care of. We're here to the end. We're here in the beginning, and we will be here in the end. And just in like Mr. Crawley said, don't stay cooped up in the house. Go outside, get some sun. You can still do fun things, social distancing, and the biggest thing, wearing your mask, washing your hands, and just remember to be kind to everyone, because everybody is going through something.
Should we also be covering our eyes?
Covering our eyes.
In the hospital, they do suggest you wear goggles.
Goggles.
I'm not sure if that's something you have to do outside per se, but
Yeah. So eye coverings have been shown to decrease the spread. It is the face shields are an alternative for those people that are unable to tolerate masks or have other conditions. So it's secondary. We still think the mask is good. But there's, as a hard recommendation, it hasn't come out, but there are studies that have shown that people that wear glasses or have eye coverings have decreased rate of infection. It just depends on the environment you're in, right? If you're in a tight environment where social distancing is extremely hard, you might really consider that.
I'm sorry, Dr. Flanall, you said folks that wear glasses are what?
There's been studies that folks that wear glasses, and I don't have mine on right now because I'm socially distanced, but yeah, people that wear glasses have a less likelihood of contracting the disease, because the eye is a portal of entry. Yes. Yeah. And you look good.
It's good to wear glasses, right? Dr. Harris, what are you going to leave us with tonight?
Yeah.
We are going through a period of uncertainty, but we are not helpless. And there is hope on the horizon. And so we can take actions to take care of ourselves and others by wearing a mask, washing our hands, keeping a safe distance, and expressing gratitude. Even I know, people are having trouble economically and missing family and friends. But, we can express gratitude for the little things in life and vote.
Yes, vote. Wow, this has been really interesting.
January 5th. Make your voice heard.
This has been super informative for me. It has been my honor to talk to you guys and you ladies to understand more about COVID. I have to admit, I'm one of those folks that deal with the anxiety around it. And so this was a learning session for me. I have a mother who has underlying respiratory issues, so I am super over the top. So this was very helpful. And I thank you for being on the front lines, Ms. Sands, Mr. Crawley. Continue to work with patients and show empathy and compassion. Dr. Flanall, thank you for just imparting us with all of this wisdom about how this virus is attacking us. And Dr. Harris, thank you for being such a phenomenal woman and continuing to make a mark on the medical community and making sure that we're keeping our mental health stable as we move through this. It is temporary and we will all get to the other side. Thank you so much for this opportunity.
Thank you for having me. Good night, everybody.
Good night.